We're going to talk about toxicology. My name is Billy Mallon. I am now at Stony Brook, where I do some international stuff, and I was a residency director like many of the people in this conference lecturing to you before. It is like a residency director graveyard. There's a reason for that. That's because as a program director, you get to see the exam and know a lot about the questions. And we're going to spend a couple hours this afternoon, one now and a little bit later, talking about toxicology. Toxicology is sometimes viewed as sort of an intimidating topic. It should not be. The reason is they can't ask a question that you need to be a toxicologist to answer. That's not the exam. The exam will be focused on the lower-hanging, easier cases where there's a toxidrome present or some obvious cues or really common stuff. That's the kind of thing they're going to ask. The last thing you want is a toxicologist up here making it way more complicated than it needs to be. So we're going to keep this into sort of a simple realm. We're going to do sort of an overview of tox. Then we're going to do the toxidromes and some things like that. And then we're going to do, in the last part of the conference of this topic, we're going to do A to Z, going through all the drugs, hovering a little longer over the ones that I think are a little more important and more likely to have questions asked about them. So with that as an intro, oh, let me say one more thing as an intro. How many people with overdoses, take all overdoses, that includes things like alcohol, who arrive at the hospital alive, die? 1%, maybe? Right? If you were the best toxicologist in the world, of the 1% that arrive alive and go on to die, how many could you save? You're the smartest, most genius, top-drawer toxicologist, poison center guru. Less than half of them. Why? Because the drug had a head start. Once it's all bound up and doing its thing, you can't stop it. And so, if you were the best toxicologist in the world, you could save maybe 0.5%, and I'm being optimistic, probably more like 0.25%, which is another way of saying that toxicology is much ado about nothing. For most of toxicology, you do really simple things that you know how to do as an ER doc. For example, they're not breathing. You might breathe for them. That would be a good idea. Their heart rate's too slow. You might try and make it pick up a little bit with some stimulation. Their blood pressure's low. Maybe give a fluid challenge and then a pressor. Supportive care is what saves lives in toxicology. It is supportive care, not specific stuff. Okay, that's the big intro. Let's go. What are the principles of toxicology? Obviously, decrease the exposure. How do you decrease exposure? Prevent it. Right? That's how you do it. Reduce absorption. For a lot of drugs, you can't do that. If I was to drink a bottle of vodka right now, and you were to turn me upside down right now, just as I finished it, and try to get all that alcohol out of me, how much would you get out? Almost none. Alcohol, cross your stomach into the bloodstream like almost instantaneously. You all know this. That's why you think you're a genius when you're having a drink. 5 minutes in, you think you're hysterical by the third sip, because right into the bloodstream. Increase elimination. We can do that. We do the charcoal thing. Know when to intervene. That's another way of saying if they're not breathing, breathe for them. Give supportive care. As I say, that's how you save lives in tox. Blood pressure's low, fluid challenge pressures. Be specific if there's an antidote and a therapy that you can give. And we'll look at that in a moment. And here's the ABCDEFs of toxicology. You know, the joke in emergency medicine, it's often said emergency physicians don't seem to know the alphabet much beyond E. That's all they always talk about is the ABCs. They really screwed that up in ACLS when they went CAB. But here the ABCs are airway, breathing, circulation, aka supportive care, decontamination if it can be done, dialysis, charcoal hemoperfusion, pukage, whatever else you need to do. Elimination, if there's a way to do that. And F is find the antidote, and we'll talk about those. A lot of drugs that don't even seem like they should. For example, acetaminophen. Look at this on this list. Is there any reason acetaminophen should cause hypoglycemia? It's not totally clear to me, nor does it need to be. The point here is anyone who's altered, who might have tox, check a glucose. Don't try and out-clever it. Just be compulsive and check a glucose. The other ones all kind of make sense that they get there. We'll talk a little bit more about alcohol and why that is. But If they're altered, they get a glucose check. Decontamination. There is some gray hair out there and some no hair. So I know where. Remember the days when we used to lavage charcoal? You remember that? With an Ewald tube. They would, no, I don't want it, no. You would fight with them and someone would hold them down and you would put a tube down and you'd get them charcoaled and then you'd lavage them and then you'd re-charcoal them. You'd take a pristine white emergency room and turn it into the Dalmatian Center with black charcoal spots all over. We learned over the years of that, from many years of doing that it doesn't really work. Most are unlikely to benefit from it, and most of the time it's because the drug is already in the system. There's nothing to be getting out. Occasionally there are times you might do it when it's a really early case, early after ingestion, delayed release product, or something that might be in a Bezor that you could get out, ingested potentially life-threatening thing that you really feel you got to get going. And so it's one of these things, but in general, all over the years, over the last decade or so, this whole idea certainly of charcoal lavage charcoal and all that kind of stuff, that, the lavaging stuff out, the decontamination stuff has gone by the boards and is thought to cause more problems with patients' aspiration, et cetera, than benefit. Syrup of ipecac, to make you puke it up, really not recommended anymore. If you were in some remote setting, 5 hours away, maybe you would do it. There's all kinds of contraindications to it. You don't want them bringing up a caustic or a hydrocarbon, things like that. People with things like bleeding disorder, seizures, altered mental status, you don't want them to aspirate. So lots of reasons not to do that. In general, questions that ask, should you give syrup of ipecac, the answer is no, unless they do a long time of explaining why it might be the right place. Lavage, again, I just went through this, uncommonly used. When might you? Recent ingestion of a life-threatening agent or something that's not bound by charcoal. That was why we used to do the charcoal lavage charcoal. Charcoal to bind it, then lavage it out. Boy, that was way too much work for that, for the benefit, which was really none. Large bore or gastric tube, remember you're trying to get things out, pill fragments, etc. You put them in left lateral decubitus, want to protect the airway, and the contraindications are self-explanatory. Now, charcoal, it really works. There's activated charcoal, and there's highly activated charcoal. I don't know if you've ever even looked. The highly activated charcoal is actually more active. It actually has a greater surface area. It's true. In massive overdoses, you might need more than a single dose. Remember, some of the charcoal products come with a cathartic, and some don't. If it comes with a cathartic, you have to be a little bit careful because repeat doses of the charcoal plus cathartic result in too much cathartic. So they might say, give it until the first poop. Anytime you talk into a nurse in your department and saying, give something until the first poop, they give you that look. I don't want any poop. That whole idea of, we're going to put this go lightly in until it comes out clear. Whenever you put that order, I recommend you try this. You got some cardiac patient that you've been in your emergency department for 30 hours. Just put that order in and watch how fast your nurses find a bed for them. They do not want that thing going on in the department. Okay. The worst thing that can happen with charcoal is aspiration. So if there's any questions directed towards should you take the airway and protect it, you should. There's direct binding of these things. Then there's this question about gut dialysis and enterohepatic circulation. Theophylline is the poster child for this. The idea is that as your body perfuses the gut, it'll still allow the charcoal that's in the gut to take drug off that circulation and have GI elimination. And so drugs with enterohepatic circulation like theophylline could have ongoing elimination by this route, and you might want to give serial dose charcoal to make sure that the gut dialysis of an enterohepatic recirculating drug is happening. In fact, the joke for years was, why do we keep using theophylline? And the answer was to maintain the toxicology fellowship training programs around the country. Because theophylline is a drug that at low levels, not even necessarily toxic, can cause cardiac toxicity, right, with VTAC, VFib, dysrhythmias. It's a drug that even before they're toxic can cause things like status epilepticus. It was a great drug. It had this enterohepatic circulation. It was like half of toxicology fellowship was theophylline. What's poorly bound to charcoal? This is kind of an important list. At the very end of this lecture in the slide set, you'll see there's a bunch of mnemonics. And in those mnemonics are a couple of mnemonics for these kinds of things. Well, I'll point them out at the end. I'm not a huge mnemonic guy, but I'll point out a couple of those that are useful. Toxicology is one of the areas, and I'll point this out as we get to it, where pre-exam you might cram some of this stuff. In real life, you would never do that, right? Why not? Because you could look it up in 2 seconds or call a poison center. You would never clutter your mind with this garbage. Never. I mean, my mind's cluttered with lots of garbage generally, but, you know, I'm not memorizing lithium, iron, caustic, cyanide, hydrocarbons, alcohol. Even the thought of coming up with the mnemonic hurts my head. Okay. Now, there in the box at the bottom, remember the boxes are supposedly quasi-important. Avoid multi-dose cathartics, sorbitol, magnesium citrate, right? Because they fill your emergency room with lots of feces and can cause abdominal pain and perforations and other things. And particularly true, the cathartics, bad in kids. Be careful with the cathartics in kids. Charcoal hemoperfusion is another way to get stubborn drugs out that are protein-bound, right? If they're protein-bound, why would you even consider charcoal hemoperfusion? Because they're not dialyzable. Things that are protein-bound are not dialyzable, and there you see again, theophylline, the poster child for a toxicology fellowship, might be a reason to do charcoal hemoperfusion. I remember I was a resident, and this guy had overdosed on theophylline, Tegretol, and a beta blocker. That was just what was in the cabinet. And it was perfect. He was therapeutic on the Tegretol, so he never seized. He had just enough beta blocker to prevent him from getting VTAC or VFib. It was like a perfectly balanced overdose. We looked at him, we said, "You're looking great. All your overdoses counteracted each other." He looked at us with this confused look. What have I done? All you got, the penalty for this is, it's like hockey, right? He got 3 days in the ICU for stupidity. Worked out just fine. Whole bowel irrigation, everyone's favorite, except, as I say, except for your nursing staff. A lot of the metals are in there, iron and lithium, sometimes drug packers, and then lead. We'll look at those things. All right, now, there used to be a time, and some of you are old enough to remember the days we used to give people ascorbic acid? We used to acidify the urine. We also then follow it with like a bolus of normal saline. We forced, diuresis. And so forced alkaline diuresis, bad idea, a dead idea largely in toxicology. Urine acidification, a dead idea in general in toxicology. I would write those two ideas down. If they show up as answers, forced alkaline diuresis or urine acidification, I can tell you without even seeing the question, it's wrong. Don't bite on that. They're wrong. We don't do this. Now, we do urine alkalinization to bind toxins to increase uptake, in particular for salicylates, which is where the question almost always comes up. An aspirin overdose with a little agitation. It's a lady with arthritis. She might have a low-grade temp. She's got an increased respiratory rate, and they'll talk to you about it. And remember that when you go to alkalinize the urine by giving it a couple amps of bicarb, right, or giving it in their fluids, you can't pee electricity. I have peed on an electric fence. That you can do. It doesn't feel good. But you can't otherwise pee electricity. And so if you'd like the HCO3 minus to get into the urine, you need something with like a plus charge to go with it. And so you will fail to alkalinize the urine if they have hypokalemia or hypomagnesemia, because the positive things that they want to put in that urine to go with that HCO3 minus are those. And so if you're having a hard time alkalinizing the urine, getting it to its goal of pH of 8 or something like that, even 7.5 is hard to reach for a urine pH if they're hypokalemic. So give K, and if that's not working, give MAG 2. Many of you know I'm a MAG lover. Love me some MAG. Can't tell you all the places I love MAG, not the least of which is a theophylline overdose to protect them from dysrhythmia, but there you go. All right, hemodialysis. Salicylates, lithium, all those things that are water-soluble, all the alcohols. Some people forget that occasionally someone just super drunk, like the frat kid that comes in. I had a frat kid who was I'm not making this up, at a casino outside LA, brought to us, and his alcohol level was 777. That was his alcohol level. And we ended up having to dialyze him for a super high alcohol level. So all the alcohols are dialyzable. And if they're really sick from them, you can do that. What are the properties there? Low protein binding, low molecular weight, smaller volume of distribution, meaning it's all in the serum. All right. These two zebra-striped pages that I have here are the list of antidotes. Many of them you know off the top of your head. Some you forget or you could get confused. These 2 pages are worth reviewing before you go into the exam. This is crammable stuff. These 2 pages are the kind of things you tear out of this notebook for little important pages of shit I might look at before I go and take the exam. And it's nicely done in alphabetical order there for you. And there you have it, okay? So this is worth looking at. And I'm not going to go through them all. We'll go through them when we're talking about the drugs, but there you go. 2 pages of antidotes. There is 2 pages, right? Yeah, antidote 2. There you go. All right, some formulas that come up in tox. I mean, you've been doing emergency medicine for a long time. Just raise your hand if you think you need a calculator when you go to work. I'm with you. So yeah, there's these anion gap things and this mnemonic mud piles. They're useful, but I don't spend a lot of time doing this. But if they give you the electrolytes in the question, they want you to figure out if there's an anion gap. It's a tox question. Someone's got altered mental status. They give you the electrolytes. You're like, oh, I have to figure out the anion gap. And then I have to know the mnemonic down there, mud piles. And let me just tell you something. The I is not for isopropyl. I, not for isopropyl. It's for I and H and iron. People keep trying to bite on isopropyl there, and I've seen it for years in resins too. So know your mud piles so you don't get into trouble with it. Osmolar gap is, there's the measured minus the calculated is it. Normal gap is less than 10. If you got a big gap, and you can see here with the calculated gap, they put the alcohol in here. Most people learn this formula without the alcohol over 4.6, right? And that's because alcohol is a pretty common cause of an osmolar gap. So if you know the alcohol level, you can put it in here and add that to the osmolar gap, right? And what happens to that, all those osmoles that alcohol gives you in your periphery? They make you pee. You all know this. You only rent beer. That's why you pee. That osmolar, not only do you get the alcohol inhibiting your distal collecting tubule from resorbing water, but you got a hyperosmolar state here because of the osmolarity of the alcohol. That's why you pee so much. A couple of drinks on a flight, you ain't making it all the way to your destination without getting up to pee because of the osmolar gap that's developing. Increased gap, acetone, all the alcohols, isopropanol, methanol, ethylene glycol, mannitol, and ketoacidosis, and ethanol by far the most common. But let me go back. All those other alcohols, and particularly, we'll get into this, the toxic alcohols, the osmolar gap is important when you're trying to detect them. In some hospitals, like for example at LA County, where I worked for 25 years, we have the LA County catchment area goes in like a jigsaw puzzle into downtown. And that jigsaw puzzle piece in downtown contains all of the missions so that the homeless people in downtown Los Angeles don't bankrupt all the other hospitals. They are, by definition, the property of LA County, and they get brought to us. But if you take care of a patient population like that has high amounts of psychiatric problems and high amounts of alcoholism and other drug abuse, when you order an alcohol level at LA County, you automatically get the toxic alcohols. But in most places you work, you don't automatically get them. And so this is a reminder, if you see an osmolar gap, think of getting a toxic alcohol levels, ask for the other ones, start thinking about what it means. Because it's alcohol is what it's about if it's osmolar gap question. Urine screens, right? You do that urine screen, and everyone knows the nurses in the hospital that you work with and elsewhere, they all believe that the urine screens are like accurate, that they tell you what's going on. They really don't. There are lots of false positives and lots of false negatives in the opiates and the urine screening process when you send it for drugs of abuse. Both directions, false positives and false negatives. So one of the more important ones, where I'm at now, I'm at Stony Brook in New York. We're not the highest in the country, but we're close to, in Suffolk County, the highest for the opiate deaths. And so we have a lot of oxycodone out there and a lot of fentanyl, and even, we believe, some carfentanil on the streets in Suffolk County. So we see a lot of people dying, and fentanyl and carfentanil are tox screen negative. right? That's why it's the drug of fentanyl is the drug of abuse among anesthesiologists. I remember seeing a guy, we stripped his shirt up and it's his chest. Those are fentanyl patches. When you run out of body for your fentanyl patches, you need rehab. You need some, you need some drug counseling, you need diversion, things like that. And that's because there's no injection site, you don't get tracks, and it's tox screen negative. So that's just one example of an important negative. There are lots of negatives and false positives too. Here they are for you if you want to know them. Okay. Specific drug levels. Now, I am not a toxicologist, as I said. I never took a tox fellowship due to the tox boards, but I was the bites and stings expert for LA County Poison Center for 10 years, and as part of that, I took Poison Center call. I had a real toxicologist back me up, and so I could tell you from personal experience that specific drug levels more often lead to errors in treatment than correct treatment because people don't understand the context, the clinical context of the specific drug level they have obtained. So if you have to know, for example, when you're getting a specific drug level, like a lithium level or a salicylate level, is it an acute ingestion all at once? Is it a chronic ingestion over time? Is it acute on chronic? And without that information, you cannot accurately interpret these levels. And so they lead to problems a lot. So that really is important to know. Levels require thought. When you're going to base therapy based on a level of a specific drug, I recommend you be in contact with a poison control center with someone who knows how to do this and does this regularly. Even for simple things like salicylates. It gets screwed up all the time. I had a salicylate overdose at LA County. We told them what to do with it. We were doing the, urine alkalinization. We were fixing it. I told them she needed a long-run dialysis because the salicylates go everywhere. I told them after you dialyze her level will go to 0, and then you're going to need to wait. You're going to need to re-dialyze her shortly thereafter to try and get her out of this toxicity range. They're like, her level's only 50. It's a chronic overdose. I kept explaining to them. She died of a salicylate overdose, never having received her second dialysis run because they didn't believe us. And they didn't understand the concept of these levels in the setting of a chronic OD. They didn't want to dialyze her at all with a level of 50. They're like, this 50, we use 80 to 100 as the dialysis number. No, it's a chronic. It's a chronic. She looks like dump. The level doesn't tell you what to do. Anyway, there you go. All right, so now we're done with the first part. We've sort of done the intro. We've floated 2 pages of shit to memorize, the antidotes, many of which you sort of know. We've talked about decontamination and where we're at with some of that. We've talked about the A, B, C, D, E, Fs of toxicology, and now we're going to do the toxidromes. And the toxidromes really are simple. For any practicing emergency physician, these are, you know these, but humor me, we'll go through them. And in most of the questions that they might ask you on an exam like this, they'll give you a super in-your-face toxidrome and ask you what to do. It's not that complicated. They'll give you someone hot as hell, dry as a bone, mad as a hatter. I mean, they'll give you a toxidrome and then they'll ask you what to do. All right, so let's do them. The anticholinergic toxidrome. You see, I beat myself to the punch. Hot as hell, blind as a bat, dry as a bone, red as a beet, mad as a hatter, and I always add to this just to remind myself of the other things about the anticholinergic toxidrome, because they often come up. Can't see, can't pee. They have acute urinary retention. They can't see. They have these pupils like this, right? Their pupils. How far across is your iris? Now, I don't want to get into any intelligent design conversations because the eye has been offered up as evidence of intelligent design. But whether you're Shaquille O'Neal or a 4'6" Filipina, your iris is the same size. It's 12 millimeters across. And when your pupil is 10 millimeters, something like that, when your pupil is gigantic, it looks like there's almost no iris left, you ought to be thinking about these kinds of things. That's why they're blind and they can't see, is because they're all dilated up. They're really obvious. The causes are antihistamines, atropine, tricyclic antidepressants, phenothiazines, antiparkinsonian drugs, Jimson weed. That's the guy who comes in with the seeds in his mouth and the little, looks like cotton, right, from the Datura species plants. They're out there. That's the autumnal high because the seed pods only happen in fall. Or it sometimes happens in spring in this flower is all over Los Angeles because the kids have been finding out how to make tea from the flowers. The flowers are these nice white or purple flowers, light purple. You can make tea out of them and get pretty fucked up. that way. And where do they find the information on these things? The vaults of Arrowwood. All the information you need about how to do that stuff. We didn't have that when I was a kid, so we had to make these recipes up ourselves. When we were running low on marijuana, our recipe was as follows. The stems and the last bits of marijuana you had, you chop that up really fine. Then you take catnip, because it grows all over, you dry that in the oven a little bit. Then you chop that up. And then you add Captain Black, which is a pipe tobacco that has extra nicotine in it. And you mix that together. It'll do it. It's not smooth. It's not. You don't get the giddiness that you get. But nowadays, that was old time marijuana. I grew up smoking old time marijuana. Have you ever smoked any of their new stuff? Oh my God, the potency of the new stuff. So somebody was at my house in Los Angeles. This is like 6 months ago. Oh, I got some of the stuff. They're showing me it comes in the, the bottle, the pharmacy. I don't know what it was called. Blue Skyway, whatever it was. They all have these great names. So I took one hit of this stuff, and that was it. There were like 20 people at my house. I was erased from the conversation. I was in front of the TV with a bag of chips like a zombie for the next 4 hours from one hit. Anyway, today's marijuana, a little more potent. I was like, this is not even fun. Not even fun. Anyway, now, the Anticholinergic Toxidrome, we got the things there. You've got to watch out for seizures and agitation. Torsade de poing. Suddenly they can speak French. Of course, if they speak French, they have to go to Denny's. Why do they go to Denny's? For the 2-gram slam of magnesium. If they go into Torsade, they get the 2-gram slam. And if they're doing anything you don't like, and particularly for agitated delirium, you can give them physostigmine, 1 to 2 milligrams, IV push. And remember, the other name for this is antilirium, right? So they get delirious, you give them antilirium. It works like a charm. People worry about giving this because they say it's going to cause worsening cardiac stuff, but it works like a charm. People are way too afraid of it. You should use it. Sympathomimetics, as if you've never seen cocaine. Okay, you know what this looks like. Sympathomimetics, hypertensive, tachycardic, sweating, dilated pupils, hyperthermia. What's the difference between this and some of the other ones? The anticholinergic, dry skin, see it there, dry. The other one, wet. Now, obviously, in an older person who can't generate the sweat, they might look pretty similar. But in a younger person where skin signs are reliable, and an acute overdose where skin signs are reliable, you can use these skin signs to separate these two out. What are some of the causes of a sympathomimetic? Amphetamine, no surprise, cocaine, PCP, MDMA. And people have talked about how these are all very similar, and they are, but you can kind of tell them apart, right? If you practice in an area where you see a lot of these, you could tell them apart. For example, I remember being on the jail at LA County, 13th floor, someone's idea of a joke. They put the jail ward on the 13th floor, and I heard some Tasmanian devil noises in the hallway. And some echolalia. I was like, And there was a guy out there who was completely dusted, PCP'd up, and he was in 6-point restraints. That's when you have restraints over the torso and the chest. And somehow, and I don't know how you do this because I did not witness this, somehow he got the gurney up right behind him without assistance. Which I don't know what kind of motion it takes to do that. I can't even picture it, but he did. And then he came into the emergency room in the jail service, a little 4-bed emergency room. Gurney still attached. And he looked at me and said something like, nah, nah. And I was like, great. And then he turned to the object of his desire, which was the sink. The porcelain sink, which he promptly ripped out the wall, water spraying all over the place. And when the cops because we have sheriffs because it's a jail, it's in pay. When the sheriff showed up, he pointed the sink at them like it was his weapon of choice. Now, that is very distinct for PCP. It is the only thing that causes severe porcelainophobia. If anyone comes to you and they report that they ripped the soap dish out the wall or the sink or the toilet out, it's PCP. It's the only thing that makes people attack porcelain. It's very identifiable. The amphetamine, they're a little more paranoid and they're picking at their skin. The cocaine, a little more chest pain because of the vasoconstriction. These are identifiable if you see a lot of them. Treatment, benzos, more benzos. Fluids, benzos. Supportive care, cool them if they're hyperthermic. Okay, opiate toxidrome. Now, this one's a little complicated. remember from medical school, right? There's all these opiate receptors, mu, delta, right? There's all these kappa. There's all these receptors, and underneath each of those categories, there's like 5 different subtypes. And that's why some opiates give you weird shit that doesn't look like an opiate. Most of them give you pinpoint pupils. Most of them give you depressed mental status and hypopnea. They, small pupils, not breathing. That's what you know, and that's what you should know for the exam. But occasionally, an opiate gives you dilated pupils, agitation, and seizures. So remember, test for opiates and consider Narcan in some cases where the clinical toxidrome might not fit this perfectly. But we all know pinpoint pupils, not breathing, give Narcan, and causes morphine, heroin, Demerol, codeine, diphenoxylate. Remember, there's a lot of weird. Remember Propoxyphene, Darvon? Darvon's a classic example. Darvon in an overdose causes agitation, dilated pupils, and seizures. That doesn't sound like an opiate. In fact, all of the D drugs, I call them the D opiates. Demerol, right? It's got the N-Meperidine when it's metabolized. Remember, that's why we stopped using it. It's got that neurotoxic thing. It can cause seizures and dilated pupils. That doesn't sound like an opiate, but Demerol will do that, particularly in a sickler who's been taking really high doses and stacking them at home. Diphenoxylate is another Lamodal, right? It's got the atropine. Be careful reversing that because you're going to get unopposed atropinism. And then finally, remember that clonidine, not Klonopin, clonidine, can mimic an opiate overdose. A lot of the jail patients who were withdrawing from their heroin and from their opiates in jail, they say they have hypertension to the jail doc. They try and get clonidine because they know it's going to partially treat their opiate withdrawal. And they also eat the clonidine patches sometimes, which is a bit of a problem. They look delicious. A little mustard, they go right down. Treatment, naloxone. Start low, always with naloxone, titrate up. Remember that for fentanyl and carfentanil and some of the higher potency things, you might need more Narcan than you're used to giving. And that's been happening a lot, and it's well described, and the opiate epidemic and all that stuff. So that is a question that could come up, that you've given 2 milligrams of Narcan, and they're not completely resolved. What should you do? And the answer is give another 2 milligrams of Narcan. Keep going. So for fentanyl, carfentanil, we had an overdose at Stony Brook. Again, I just report the news as it comes to me. We had an overdose at Stony Brook. This guy died, and they thought it was carfentanil. They had a really hard time reversing him, et cetera. And then the next day, his girlfriend came in, and she was overdosed, and we reversed her, and she was doing okay. And we wanted to ask her, did she know was her boyfriend using carfentanil? And so we asked her this question, and she looked at me, she said, well, doctor, I did get it out of the glove compartment in his car. I was like, that doesn't mean it's carfentanil. I appreciate that you got it out of the car, but that's not what the car and carfentanil is about. But thank you very much for playing. Did I finish everything on there? Yeah, treatment, naloxone. Okay. All right, now we switch over to the cholinergics, right? You all know this: sludge, salivation, lacrimation, urination, diarrhea, gastrointestinal upset, and the killer bees. The killer bees are what the treatment's all about: bradycardia, bronchospasm, bronchorrhea. Remember, you do not treat to the pupils, you treat to the bronchorrhea, bronchospasm, bradycardia. They have pinpoint pupils here. And then there's the nicotinic effects, right? They always ask this: muscarinic, nicotinic. This is kind of important. This is stuff I don't hang on to and use in my daily stuff, but it makes for great test questions. This nicotinic, muscarinic crap, it's never really been that important to me in real life. But there you have it. Nicotinic effects: muscle weakness, fasciculations, respiratory failure. Obviously, the respiratory failure is a problem. Especially caused by bronchorrhea, right? You give them, so how much atropine are you giving them? You're giving them enough to dry up their secretions so they can breathe, so they don't die of respiratory failure. How much atropine might it take in one of these cholinergic overdoses? All the atropine you got, all the atropine the units got, and all the atropine your neighboring hospitals got. I've been up to 20 milligrams, 25, 30 milligrams on cases. All right. Particularly when it's an organophosphate, these insecticides. There are some mushrooms that do it. Why does this come up? Because it's part of terrorism as well, chemical warfare agents. And so what do you want to do with those? You want to treat them until the secretions are dry with atropine and 2-PAM. Okay? And finally, we're on to the last toxidromes, withdrawal syndromes. Now, it's interesting. We always say that with benzos, no one ever dies of a benzo overdose unless They choke on the pills. Right? Because you take benzos, you drink alcohol until you fall down and stop taking more. You're sedated, you're maximally sedated, you stop. So you don't die of it. And the supportive care is pretty easy for these. However, the withdrawal syndromes for these are potentially lethal. People do die of delirium tremens. People do die of benzodiazepine withdrawal. Xanax. How many people are seeing a lot of Xanax and Raggedy Edge? Xanax is a nasty benzo, and it really has some nasty stuff, both in overdose and withdrawal. Xanax is kind of nasty. But there you go. What do they get with the withdrawal of these agents? Diarrhea, mydriasis, hypertension, tachycardia, insomnia, cramps, diaphoresis, etc. Treatment is benzos. You might do clonidine. I don't want to get into the argument with it, because even the tox people argue about it. I'm a believer in phenobarb if the benzos aren't working, if you get up to higher levels. And that's where you go with those. They need fluids, generally speaking. Let's talk a little bit about the diagnosis of delirium tremens, since we got the picture of the beer label there. Delirium tremens. To have delirium tremens, you have to have D and T. Delirium and tremor. But that's not enough. The entity DTs was defined in such a way to identify those with severe enough withdrawal that they need to be in an ICU. To have DTs, you need to have D and T, and dysautonomia with all three of hypertension, tachycardia, and fever. And so a lot of times what people call delirium tremens isn't. It doesn't have a fever, for example. The fever is supposed to be due to their withdrawal in that definition. All right? So DTs is overused as a diagnosis. Most people called DTs don't actually have it. So what you should call them is severe alcohol withdrawal, impending DTs. That's sort of the correct verbiage if you want to be particular about the diagnosis. All right. Where does this take us to? We are now done with the first couple parts of this lecture. We've done the toxidromes. We looked at the general stuff. We did the 2 pages of antidotes. And now we are to the hard part of this lecture, which is the alphabet. A to Z, we're going to go through drugs. Now, if you were to take all the levels away from me and said, Dr. Mallon, you could only have one level. Only have one level? What do you mean? That's a, what do you, of course I could have all the levels. No, you can only have one level. We're tired of you people misusing the levels, not knowing what the hell you're doing. We're only going to give you one. Acetaminophen would be the level you would get. And you should get acetaminophens liberally on patients who have overdose, because acetaminophen is all over the place, and it's lethal, and it's treatable. And it has some silent phases of its intoxication. If there was ever an overdose level that I wanted, it's for a lethal, treatable drug that's everywhere. So the most important level you can ever order is acetaminophen levels. Again, what did I say about getting levels? You need to interpret them appropriately. Is it acute? Is it chronic? When was the last dose? You got to know all that stuff. And if you don't know that stuff, there are still ways you can use the levels serially, but you need to know what you're doing. Toxic metabolites, right? If you want to hang out with the toxicology party, you got to be able to talk about NAPK. You know, that's the toxic metabolite. And you got to be able to talk about the 3 metabolic pathways of acetaminophen. It's the middle pathway that generates the NAPK down there. And NAPK causes a problem. It eats up all your metabolizing, all your reducing potential. And so when you give the antidote to this, you're restoring their ability to reduce further overdose. Now, here's the 4 stages. People don't think about this much. Stage 1, a little bit GI symptoms, and then they resolve. Stage 2, asymptomatic. A lot of people who have Tylenol overdoses come to the emergency room relatively asymptomatic from them. They're still going to die, though, maybe. That's why I want the level so bad. Then they get some LFTs going up, some GI symptoms, and a recovery phase if they didn't overdose too much on it. And so this is, anytime you have a lethal common overdose like this where a level would help you out, this is why I want this one so bad. Now, if you want to prevent liver failure by Tylenol, how do you do it? Yes, you give the antidote, NAC, N-Acetylcysteine. But what do you really do? What do smart countries do? Implying we aren't one of them, because certainly we aren't. What do smart countries do? They know that overdoses aren't meticulously planned events. They know that you have to, as an adult, you have to eat more than 7 grams of Tylenol at one time to get liver failure. So they force the pharmaceutical industry to limit their packaging to 7 grams in a blister pack. We won't have any of that in the United States. And in the United States, you should be able to go to Costco and get enough Tylenol to kill a village at a half a cent a pill, and it should be stored in an open 55-gallon drum in your bathroom so that you can overdose anytime you want. And in civilized countries, Tylenol overdoses are responsible for about half the liver failure and half the patients on the organ transplant list. So in the UK and in, that means all of those places around the UK, right? Not just England. In the UK, just for Trump I said that. In the UK and in Italy and other places where they are smart, they just limited it to 7 grams of Tylenol in a blister pack. Let me do my imitation of an typical overdose in the United States. I hate you so much, you don't want me. And then into the bathroom, whap, boom, boom, and then open the cabinet. What's in here? I'm going to take all those. And because that bottle in the United States contained 50 grams of Tylenol, that woman's in big trouble now. And she doesn't even know it was dangerous because it was just Tylenol. She thought it was a suicidal gesture when in fact she's actually going to die. And she's going to have liver failure. She doesn't know that. But when it gets found out. Now, here's what happens in the UK. They say with that, oh, I hate you, bloody bastard. And then she goes, and then she's in there, I fucking hate him. I can't get these out of here. And then she gives up. And she, what else is in here? And she drinks like the Vicks Formula 44. She could only take 5 tablets of Tylenol in her rage. And so she doesn't die of a Tylenol overdose because she couldn't get them out of the blister pack. Okay. What happens with an acute OD of acetaminophen, toxic ingestion? Remember the old 140 rule? If they have over 140 mg per kg, which is about 7 to 10 grams, they get 140 mg per kg of the treatment if you're going to go orally. Most people have dispatched oral for IV treatment of these. What does N-Acetylcysteine do? It prevents binding of NAPK and may also reduce NAPK. It adds reducing potential. There are oral and IV preps. It's safe in pregnancy. Charcoal doesn't stop it. Still indicated late, even greater than 24 hours out. Even with the liver functions blasting towards the ceiling, you can do it. Here's the Nomogram. We don't really use this unless it's an acute overdose, so be careful of using the Nomogram. It doesn't work in chronic overdoses, so you have to be more careful than that. Although on the Nomogram, you can see the 4-hour level. See at 4 hours, that level's is about 140 at the top left of that diagonal line. So that's where you get the old mnemonic. If it's greater than 140, they get 140 at 4 hours. That's the old idea if you're going to give it PO. PO, by the way, is a great way to give it, right? Because PO, it goes right into the GI tract and gets picked up by the portal circulation and taken exactly to the organ you want it to go to, the liver. So there's no real advantage to giving it IV unless the patient, of course, is puking too much to take it. And there's one other advantage to giving it IV. The IV treatment protocols are shorter than the PO ones. And so since they can't go to the psych bed until you're done with this medical treatment, everyone wants to go IV with these nowadays because these patients are really good company. You want them to go there. All right, we're still in A of the alphabet. Alcohol, another really common problem. Alcohol withdrawal, we just talked about. The DTs, we talked about. Treatment fluids, thiamine if they need it. You know, you don't have to give a banana bag to everyone, but people who are having problems with chronic alcoholism and other problems, they look nutritionally depleted, those are the times you do it, that you would consider doing it. Wernicke's encephalopathy down there, right? Oculomotor crisis, cranial 6 palsy, the lateral rectus, nystagmus, ataxia. Remember, wet, wacky, and wobbly is in there for, that's normal pressure hydrocephalus. But these get the inability to see there. And Korsakoff's, which has the confabulation. Now, the other thing to remember is alcohol was on the list of why you get hypoglycemic. Let's go over that for a second. Why? So when you see drunk patients in the emergency department, if you're going to give them fluids, really they should get D5NS. And the reason is that if you're living on vodka, right, you're drinking vodka, you can ask anyone, is that a low-calorie diet? No, there's a lot of calories in there. But you can't make sugar out of it. What do I mean by that? You can't take the 2-carbon ethanol fragment and add it to another 2-carbon ethanol fragment and add it to another 2 carbons of ethanol and say, voila, sugar. 2 plus 2 plus 2 equals 6. Your body doesn't know how to do that. Your body can do 3 plus 3 equals 6, right? But if you're living on vodka and all you got is 2, you can't do 2 plus 2 plus 2 equals 6. What is that? That's called photosynthesis. So unless your patients have leaves, they can't do that. And so if they're living on vodka, they tend to get hypoglycemic because the 2-carbon fragment. And that's why drunks who live on Guinness, for example, they don't get this because there's a lot of complex carbohydrates in Guinness. That's why they have the ad with the toucan, Guinness for strength. It's got all those complex carbohydrates in there, so you won't get hypoglycemic. But if you're living on vodka, indeed you will get hypoglycemic because you can't do photosynthesis. Okay, and that's why alcoholic ketoacidosis is similar mostly to starvation ketoacidosis because you're hypoglycemic with it. All right, now we're talking about methanol. Where do you get methanol? Paint thinner, window wash solvent, wood alcohol, gas tank additive, and more often, bad hooch. Bad hooch in Southeast Asia, bad hooch in the United States. They'll have an anion gap acidosis, and I'm talking a severe anion gap acidosis. One of the things about methanol, of the bad methanol cases I've seen, and this will really stand out to you, you guys have seen lots of DKAers who are sick, right? Sick DKAer. How low is their bicarb? It's always the same, 4, 5, 7. They got a pH of 6.9, bicarb of 5. When you see a methanol overdose, and there aren't many things that do this, you get the labs back, bicarb 0. That gets your attention, 0. When it says 0, you should think methanol. That's just the kind of acidosis you get with this. And they have problems with their vision, they get disc hyperemia, and they got an increased osmolar gap, and they really need dialysis. Now, what are the other things that I would highlight on this page? See that pancreatitis down there? The visual changes and blindness. The very bottom of that page is worth noting. They might ask, is it the methanol that kills them? No, it's the metabolic products of methanol. So after alcohol dehydrogenase gets a hold of it, then you start making formaldehyde and formic acid and other things. All right. Treatment, famipizole. You can give them ethanol to try and fix it. All that does is slow the metabolism down, the ethanol. You're trying to compete for the metabolic site. And then dialysis if none of those other things are working. But I would tell you, in a severe methanol overdose, you really should be thinking of the famipizole or the ethanol as temporizing measures while you get dialysis available. Because what's it like when you call for immediate emergency dialysis in your emergency room? Do they sprint down to the emergency room, dialysis machine, set it up, quick, get the dialysis? Or do you feel like that you could tell where they've been by the slime behind them, the snail track? We're coming. Anyway, so a lot of times you have to temporize them, and how do you temporize them? It's famipizole. I had a friend who was at Camp 4 on Everest, and they had a patient who drank some, they had a climber who drank some hooch with methanol in it. So he's all screwed up. They're like 22,000 feet or something. And they're like, what are we going to do? What are we going to do? And they're like, she's a smart ER doc, and she was like, we need some alcohol. They're like, we don't have any alcohol. We're climbing. We're at 22,000 feet. She said, the Russians have alcohol. Trust me. So they did. They went over to the Russians and got some vodka and made up some IV fluid with vodkas in it and saved this guy and took him down so he could be evac'd out. It worked, it temporized them. All right, now we're on to ethylene glycol, the antifreeze, other solvents. Often these are colored, right? They have colors to them so that you know that you're not supposed to drink them, which, does that work? So you got like a pink, a blue, and a green bottle in your garage. So you know not to drink them. But the 6-year-old who's in the garage, Kool-Aid! And down they go. And so that happens. Now, this is an anion gap acidosis again with an increased osmolar gap, right? We've been saying these kinds of things. And the oxalic acid precipitates in the urine, and you make these crystals that you'll see on the slide. Renal failure, hematuria, hypocalcemia. So the last one was pancreatitis and the blindness. This one is renal failure, hematuria, crystalluria. And treatment again, famotidine and dialysis if severe. Similarly, the famotidine is your bridging treatment. And then final, a rubby. We used to see lots of rubbies at LA County, or people who are withdrawing from alcohol. They find some rubbing alcohol, they drink it because they think it'll help them with their withdrawal. And they get hemorrhagic gastritis, pulmonary edema. And remember, this one does not cause an anion gap acidosis. It is not part of mud biles. It causes ketosis, but no acidosis. If they have a little bit of acidosis, their acidosis is usually from what? Alcoholic ketoacidosis. I'm done at what time? 2:15? 2:15. I'm watching. All right. So now we've gone through the toxic alcohols, and you see at the bottom increasing toxicity of them. Ethanol is the least toxic, although it by far causes the most deaths. How does ethanol cause deaths? Trauma, car accidents. Half of all fatalities. If you look in the United States, it's fascinating of how people die, and ask, is ethanol involved? So we know half of all motor vehicle accident fatalities are alcohol related. You might say, let's go look at farm fatalities. People dying on the farm, that pastoral, healthy life. No, half of them are hammered. When you live out on the farm, there's nothing to do but drink. Half of all farm fatalities hammered. You look at fire deaths. Come on, no, half of them are drunk, more than half in some series, 2/3 are drunk. No matter how you die, alcohol, if you look at murdered and you include either the murderer or the murderee, way more than half. Alcohol is just trauma, and any way you can die, alcohol's in there. All right. Amphetamines. Now we're on to talking about sympathomimetics, and we can talk about cocaine first. Remember, cocaine is a vasoconstrictor. That's why they get the chest pain. But remember also, they're often smoking it with rock cocaine, right? With the bad screen. You ever seen anyone suck the screen out their rock cocaine pipe and it hits the back of their uvula like a Sizzler ad? Whoosh! They come in with that uvulitis from sucking a superheated rock screen out of their pipe. So these things you'll see with this. And a lot of people you see in the inner city that are blind, you know, they got that white cornea. You ever seen these people? Who's working at county hospital? You'll see these people walk around county hospitals with the white cornea. Some of them were stabbed or shot in the eye. That's true. Some of them had some eye disease, but in a hospital like LA County, half of them killed their eye smoking the rock cocaine, right? Torching it, so you got to picture the 6-inch blowtorch going to their rock cocaine pipe. But they don't know that they're burning their cornea because the fumes coming off are cocaine fumes that are numbing their cornea. So over time, they cook their right cornea because they're using their right hand to do the lighter. So a lot of that's what you're seeing. That's cocaine keratopathy specifically. Other cocaine associations that you got to know, and I used to work at California Medical Center downtown, and boy, did we used to deliver some cocaine babies, preemies with abruptio placenta. So abruptio placenta is specifically due to the vasoconstriction associated with cocaine. Oftentimes it happens around the 28th, 30th week. You'll see these things. They get abruption, and then they go into labor. Status epilepticus occasionally. The rhabdo is real. If they have a lot of muscle pain, get some fluids in them. Stroke and MI. Because of the vasoconstrictive components. Why is everyone who comes in with cocaine on board also drunk? They always are, 100% of the time, particularly if they're smoking rock cocaine downtown. Because they're not stupid. If you smoke rock cocaine all by itself, with no other adulterants in your symptoms, you'll absorb it very rapidly, huge pulmonary absorptive surface area, boom, straight in, almost as fast as shooting it, boom, straight into the bloodstream. You'll be high, your heart will be pounding, you'll be vasoconstricted, you'll have a great thing, and it'll last about 40 minutes at the most. And then you'll be needing another rock. But on the other hand, if you drink a nice, cold, gulpable, strong alcoholic drink, the Cobra. You wonder why people downtown are drinking these fortified beers. You get your alcohol level up to 100, 150. Now you smoke your rock cocaine. In your system, you form cocaethylene, which has a 6-hour half-life. Now you're lit for 10 hours. That's why they come into the emergency room very late in the night or early in the morning, because they're not coming down until at that point. So cocaethylene is neuroactive, vasoactive, and so everyone who's smoking rock cocaine will make sure, and you don't want to drink vodka when you're doing that. Why? Because the rock cocaine burns at a really high temperature. You're frying your throat. even if the screen doesn't come out of the pipe. So you need cold gulpable. Think Irish rose wine, think malt liquors, think things like that have enough alcohol to keep your alcohol level up, but won't burn your throat going down. And here you see someone infarcting. It could be the cocaine, it might not. And nowadays, because people are using other drugs, your cocaine abusers, if you're at a county hospital in Los Angeles, for example, who are they? Are the 20-year-olds coming into LA using cocaine? No, it's kind of passé. They see it as my generation. So the older guys are the ones coming in, still using cocaine. Remember the Richard Pryor line? I know someone using cocaine 15 years ain't hooked. But anyway, so it's an older, so now you're seeing 50, 60-year-olds using cocaine, and they also have some concomitant heart disease, so they are infarcting more. So who knows whether it's the plaque rupture or the cocaine. The antabuse reaction, they love this on exams. The question will always say something like, a woman who was at her, gynecologist last week or something like that. They're trying to get you to realize that she's on Flagyl, and they get an antabuse reaction with the alcohol, the flush face, marked diaphoresis, nausea. They can be really sick. I've seen people who needed to be admitted because of this. They can be full-on miserable with hypotension. They can get seizures, dysrhythmias. So the antabuse reaction, which sounds kind of like, that'll serve them right. No, it's serious. You need to take that seriously. And on the questions, they want you to not underestimate the seriousness of this. Then we get into arsenic. Like arsenic was all those, British, whodunit films about how to kill somebody. Sources: wood preservatives, weed killers, pesticides, symptoms, GI, muscle twitches, delirium. The diagnosis: 24-hour urine, and you chelate it. This probably won't be on the exam. We'll move. Barbiturates, also an old-time drug. A lot of the younger people haven't seen barbs. I remember the days of what they're showing in the picture here, Barb Blisters. How do you get Barb Blisters? You'd use enough of a downer, not enough to kill you, right? No one dies of a hypnotic overdose, but enough to fall asleep on your arm for like a day. Then when your arm comes out from underneath your body, they're pressure blisters because you haven't moved an inch while this was underneath you. We had one come in the other day with Barb Blisters to Stony Brook, and they were like, I don't know how this, call the burn service. I'm like, relax, it's not a burn. These are Barb blisters, these are pressure blisters from over sedation and falling asleep on their arm. And he had a compartment syndrome, the whole thing. So short-acting barbs, pentabarb, secobarb. Long-acting barbs are the dialyzable ones, so that's the question there. If they ask about dialyzability, the short-acting barbs with their high lipid solubility are non-dialyzable. Secobarb, pentabarb, non-dialyzable. They ask that question every once in a while. When I say they ask that question, I'm going to end on this concept because we'll be talking a lot over the next. I would not ever be talking about the American Board of Emergency Medicine and their proprietary information for which, if I divulged it, I would be strung up and killed. So when I say they ask that question, who would I be talking about? I would be talking about the Royal Examining They. People who have been program directors and written exams for their residents, people who do review courses or write those books or other things. Those are the they to which I refer. I would never be divulging the kind of information that comes straight from the American Board of Emergency Medicine. I would not reveal their questions nor their oral exams. When I talk about they like to ask that, I certainly do not mean those assholes. I'm talking about people who don't charge $1,000 for their exams. They actually give them to their residents every couple of months, that kind of thing. That's the they to whom I refer. All right, so here you see this picture: meiosis, CNS depression, treatment, lavage, charcoal urine, alkalinization again for long-acting only. So here you see long-acting, dialyzable, and you can alkalinize. Short-acting, non-dialyzable. They might need charcoal hemoperfusion. And I'm going to end there. It is 2:14. You can see how far we got in the alphabet. It's kind of discouraging, isn't it? We're finishing up here, and we're at B. Let me see what the next slide is. Let's pray it's a C drug to say that at least we've done A and B. No! All right, we will come back to benzodiazepines. And who's up next?